Well, good morning, everyone. I'm Dr. Laura Lacher, and welcome to today's Medical Grand Rounds. We'll go ahead and get started with some logistics and then introductions for today. Next week's talk will be given by the cardiologist, Dr. Michael Layun. The talk is Advanced Cardiac Imaging for the Internist. And just a heads up that will be a virtual only presentation next week. Speaking of, I am here live at Providence St. Vincent and Southern Auditorium. Many of you know that Grand Rounds is now a joint effort between Providence St. Vincent and Providence Portland Medical Centers. We are typically here live in the room on Tuesday mornings at 8 a.m. and sometimes live at Providence Portland, also on Tuesdays at noon. You can learn exactly where and when Grand Rounds will be each week if you look at the weekly invite. And you can earn CME credit by being here live in the room, by watching on Teams Live, or by watching a recording of the event. And that recording is also available on the weekly email. I'll be monitoring the Q&A throughout the session today, so for those of you joining us online, be sure to post any comments or questions, and we'll integrate those mostly at the end as time permits. And now for introductions. We're joined today by Dr. Evie Hobbs. Dr. Hobbs was born and raised here in Portland, Oregon, and began her oncology career as a Cancer Research Training Award recipient at the National Cancer Institute. She attended medical school at UCLA, followed by residency in internal medicine at OHSU, and then went on to do fellowship at MD Anderson Cancer Institute. She is now a breast medical oncologist at Providence St. Vincent. She is co-chair of the Cancer Molecular Tumor Board and actively leads clinical trial development and the Breast Cancer Molecular Research Registry with an interest in targeted therapies and understanding disease resistance. Dr. Hobbs, thanks so much for joining us today.
Well, thank you. I think I'd just like to start by saying breast cancer is very prevalent. So within Oregon, there's roughly 4,000 to 5,000 patients that are diagnosed with this every year. And very few people I know haven't been affected by breast cancer in one way or another, either family or friends. So with this Grand Rounds, I'm assuming you understand at least some basics about breast cancer, but really to provide some of the controversies and updates within our field, what we're doing in medical oncology, and also within the Providence Cancer Institute. I have no relevant disclosures. And really, this is going to be broken down into 3 parts, starting with risk factors, genetics, screening. Part 2 will be mostly medical oncology management of early stage disease, and then we'll wrap things up with survivorship. So in regards to breast cancer risk factors, in some way these are quite obvious. So when we talk about environmental factors, most of these all relate to different ways where there's increased estrogens, namely obesity, for instance, a relative risk of 1.5. If BMI is above 30, a relative risk of 2. Alcohol is an interesting mechanism in that alcohol has estrogenic properties, but it also causes kind of an inflammatory milieu that can stimulate any abnormal growth of breast tissue. Hormone replacement therapy, now this risk is not sustained after cessation, but some of this is a little bit controversial and limited to very large meta-analysis. Early menarche, later age of menopause, older age of first birth. And what's protective is breastfeeding, exercise, weight loss, really all the things that we know we should do, what we probably could do better at. In terms of exposures, thoracic radiation, particularly in younger patients with Hodgkin lymphoma, actually can have a risk of developing breast cancer that approximates those that have a germline BRCA1 or 2 mutation. So Kristen Massimino, she's one of the breast cancer surgeons here, and we're working on identifying these patients who received radiation at a young age to get them plugged in with our high-risk clinic. And then genetics and familial factors as well. So one thing that's made its way into the media recently is a meta-analysis that showed there's an increased risk of breast cancer with progestin IUDs. And oftentimes I see these studies and invariably they make their way into the layman news. And so I've had several patients within the last year ask me, did my breast cancer become caused by this progestin IUD I've had for 10 years? And really, when we talk about risk factors, the answer is no. So these risk factors don't independently lead to mutations in the breast or precancerous breast cells. Now, if some of those cells do exist, these things can stimulate the growth of them. So in terms of this Danish registry study, they did find a relative risk across a very large population of patients. And some of it depends on age. So for those who are younger than 35, the relative risk is lower than someone who's 35 to 49. And generally, what I tell patients is if you were to have a stadium of about 8,000 women, this leads to one extra breast cancer diagnosis per year. So the actual risk is quite low when you put it in terms of these numbers. And again, some of this data is limited to mainly using higher doses of progestin IUDs. So really, if a young patient has an IUD in place, I'm not just telling them to immediately have it removed and go on and get a copper IUD, really because contraceptive mechanism and kind of things are pretty limited in this patient population. In terms of genetics, roughly about 25% of breast cancers do have a familial component to it. And of these, we've only been able to identify a fraction of what we call germline pathogenic variants or mutations, of which there's several different ones. There's roughly 9 that are mostly associated with high risk of developing breast cancer. Others are more moderate. But what we're finding is that even within a particular gene, it can have variance in what their actual risk of breast cancer is. And some of it may actually be a combination of mutations, and a lot of this work is being done by Fergus Couch at Mayo. So in terms of identifying these, really if someone's over the age of 65, it's quite rare to find a germline mutation, roughly 3%. However, if someone's younger than age 30, roughly 50%. Unfortunately, I've only seen about 3 patients who have been younger than 30, all of whom have had germline mutations. So who gets germline testing? This is constantly being updated. And fortunately, in the most recent updates of the NCCN and guidelines, it's become a little bit shorter and a little bit more easy to navigate. I think that it's important to just periodically check if they would meet criteria for germline testing or not. Oftentimes a patient will come into clinic and say, how are you doing? And, oh, my sister was just diagnosed with breast cancer and she may be 35. And that may raise some flags. Okay, well, did she get genetic testing? What were those results? Do I need to get you into high-risk clinic? So an important thing is when to repeat testing in someone who's a breast cancer survivor. Now, germline testing prior to 2014 didn't include a lot of the kind of more like newer genes that we've since identified, PALB2 being one of them. Some of those initial panels were limited to just looking at BRCA1 and 2, and they actually would miss large genomic rearrangements. So generally, if someone had genetic testing in the distant past, I do often retest. And another part of this is that for these more modern panels, it's up to 77 different genes that you're looking at. And they also include not only DNA, but RNA. And so with including RNA in germline testing, you can actually identify approximately another 10% of patients who may have actually a pathogenic mutation. I did want to note the Healthy Organ Project, or otherwise known as HOP, and the link is here. And what this is it's really available to all Oregonians, and you can sign up for this. You can get genetic testing performed for free. It's a fairly limited panel than what we do in clinic. At least when I last checked a couple of years ago, they were only running DNA and not RNA. And I actually had a patient I saw in clinic who said I had negative genetic testing just within the last year. And then ultimately, she ended up having an ATM mutation by including the RNA and the germline testing. So in terms of screening, this is really a nightmare, to be real honest with you. You really have kind of most aggressive guidelines to least aggressive, and it's really variable in terms of age to start screening. Actually, the ACR recommends that every 25-year-old female gets a risk assessment done to determine when they should get breast imaging, which is quite young if you think about it. So really, this is a little bit difficult to navigate. I tend to be a little bit more on the aggressive side, I think in part because I am biased, being a breast oncologist. But a lot of work really needs to be done in really refining this to make it simpler for people. I will note that Oregon is one of 39 states where they've actually passed laws that require breast radiologists to mention if someone has dense breast tissue or not. Because when someone has extremely dense breast tissue, they actually will qualify for increased screening with MRIs of the breast. However, in Oregon, unlike Philadelphia, they do not state MRI specifically, so insurances will sometimes give you pushback and just default to an ultrasound. So some racial discrepancies in breast screening. When you actually look at breast density alone, there's two components to it. There's breast density, but there's also breast complexity, something that we'll often call a busy breast. And if there's complexity, these patients, oftentimes there may be breast masses that are missed. So this is an interesting study, actually looking at results of screening mammograms in Black women versus white women. And depending on whether or not they had heterogeneous or extremely dense breast tissue, who would actually qualify for increased screening risk. And they actually found that only 1.6% of Black women actually met that criteria of having dense breast tissue to have that increased surveillance. Yet at the same time, these patients tend to be diagnosed with more advanced stage and kind of more aggressive molecular presentation. So this is hopefully going to be kind of brought forth in terms of our surveillance guidelines. The Wisdom study, so this was presented at the San Antonio Breast Conference just in December, and in some ways this is kind of like a no-brainer study. The whole purpose of this was really try to simplify breast cancer screening. You can look at all these guidelines. However, what does it mean for an individual patient? And Wisdom study, this actually stemmed from UCSF, and they were actually able to get Blue Cross Blue Shield to help pay for some of the screening within this. So patients received risk-based screening or annual screening mammograms starting at age 40. For the risk-based screening, all of these patients underwent a questionnaire online, and then every single patient received genetic testing, just the 9 of the top genes through a company called Color. And out-of-pocket testing, I believe, is like $125. And they risk stratified patients in terms of like when they should start screening in terms of low risk, intermediate risk, or high risk with alternating mammogram and MRI. And what they found was over 5 years, now we're still waiting on longer term follow-up. And this was really a preliminary analysis. They hope to enroll 100,000 patients into this. But there was really no difference in terms of developing a stage 2 breast cancer between both groups. The number of breast biopsies was the same, and overall, this resulted in fewer mammograms with no apparent increased risk or delay of diagnosis. A couple of other important things that stemmed from the exploratory analysis was that they found for those who had high risk, who fell into the high risk group, those women are actually more likely to take tamoxifen for prevention of developing a breast cancer. It went from 5% up to 10%. And another important note here is 2.6% actually had a germline pathologic variant, which is much higher than what we have typically thought of being maybe 1%. And 30% of these patients actually had no family history. So it really calls into question NCCN guidelines, really with germline testing being much more affordable. Should we be testing more of the population? I think we absolutely should. With this study, the ACR, there was actually a kind of a battle or tiff on Twitter between Dr. Esserman, who's the PI of this study, and AACR saying we need a lot more data before we start individually thinking about patients' risks. Here's the Wisdom study risk groups in case you're interested, if you kind of want to loosely follow this rather than the 4 to 5 different guidelines for breast imaging. And I'd like to note that here at St. V's, we actually received a donation to have what we call a contrast enhanced mammogram, which is really exciting. The only other center that has this is in Bend. And the way that this works is it uses iodine contrast instead of gadolinium. Patients have a routine mammogram. They do have an IV placed. In terms of billing, it's billed as a mammogram with a code just billing for the contrast, so significantly cheaper than an MRI. As things stand now is that for high-risk breast cancer patients, we're recommending alternating with MRIs and mammograms. But if you imagine someone who's in their 30s undergoing high-risk screening, maybe for a decade, this is a lot of breast imaging, a lot of MRIs. So I think this is absolutely wonderful. It's great for older patients who can't tolerate MRIs or have claustrophobia. We're still waiting on some additional data and guidelines for this to come forth. But recently published was the UK trial, which looked at 9,000 women with contrast-enhanced mammogram compared to MRI or ultrasound, which sometimes we'll use for heterogeneous breast tissue. And they actually found that the cancer detection rates between contrast-enhanced mammogram was equivalent to that of MRI. And it was actually far lower for ultrasound. I would have expected that to be a little bit higher. And to the right, you can see the difference between 2D or 3D mammogram compared to contrast-enhanced. And you see this is kind of what we call a busy breast or dense breast tissue. So there's a New York Times article highlighting breast cancer rates are climbing amongst young women. And within my own clinic, I don't know if it's a little bit of a referral bias, but I tend to have quite young patients. And so I do feel this. In terms of the last decade, when you look at increased risk of an invasive disease, it increased roughly 1.4% compared to those above the age of 50, which was 0.7%. And interesting, this was also noted, this increase was also noted amongst Blacks, Hispanics, and Asians. And some of this is a little bit obvious going to our risk factors. Women are having kids at an older age. They may have only one kid instead of several kids. There also may be endocrine disrupting chemicals, maybe microplastics, I'm not quite sure, and then alcohol as well. But truth of the matter is we don't know. In terms of colorectal cancer, we're running into the same issues. But I sure hope it's a trend that stops soon. So if there's anyone that you think has needs to be seen in high-risk clinic, refer them to the breast care clinic at St. V's. Those with breast dense tissue, family history, even for benign or symptomatic conditions. We actually have social work support, which is really nice. There is a patient with leaf-Romani who was recently seen, and she had multiple family members pass away at a young age, and we were just immediately able to get her that help. And then, of course, just really quick referrals to get into CS. All right, so I'm going to pause here, see if there's any questions about anything within this first part. Not, it's okay, we can power through. Okay. All right, so part 2, early stage breast cancer. Approximately 90% of breast cancers nowadays are diagnosed early stage, where fortunately a minority of patients are diagnosed with what we call de novo metastatic disease. So in terms of breast cancer basics, I often will draw this little figure out for patients, new patients when I see them in clinic. Breast is made up of lobules or milk glands as well as ducts. And really, there's a progression between what we call atypia or precancerous lesions, the development of atypical ductal hyperplasia that then can progress to DCIS and ultimately invasive carcinoma. So approximately 80% of breast cancers arise from the milk duct. However, I do want to note that those that arise from the milk gland, something we call invasive lobular carcinoma, makes up about 15% of all cancers. But this can actually be a very challenging type of cancer to treat. It's almost always hormone receptor positive. It's actually characterized by the loss of a particular protein that allows those cells to stick to one another. So when it grows very spread out within the breast. Often there's not a palpable breast mass. Patient may have some asymmetry seen on a mammogram. It's biopsied, and then they have a MRI. It shows a 3 centimeter area of non-mass enhancement. They go for breast surgery, a lumpectomy, and rates of there being a positive margin is sometimes as high as 30 to 50%. And it really is due to the challenges in being able to image this particular type of breast cancer. To make things worse, it has kind of an odd kind of distribution of metastatic recurrence. So while it tends to go to lungs, lymph node, and bone, like more traditional ductal carcinoma, it can go to some odd places. So I've had patients present with recurrent lobular breast cancer 10 years after diagnosis on a routine screening colonoscopy with involvement of their cecum. So it can go to the lining of the GI tract. Another patient diagnosed with recurrent pyelonephritis, which is actually lobular breast cancer coating the lining of the ureters. Again, no breast mass. And then also leptomeningeal spread too, which is involvement of breast cancer within the CSF. Another patient presented with what they thought was optic neuritis. So I just wanted to highlight this because it can be a sneaky type of breast cancer, just for you to have it on your radar. Breast cancer basics, 3 main subtypes: hormone receptor positive, HER2 positive, and triple negative. Majority of these are hormone receptor positive. But within each of these subtypes, I kind of frame them as there's slower growing, more indolent, and kind of fast growing aggressive. So even for triple negative breast cancers, there's a condition type called apocrine, which tends to have a more indolent growth pattern. So not all triple negatives are created equal. When you look at the breast pathology report, these are a couple of the main things I look at. First, it will say invasive carcinoma, that's breast cancer. Oftentimes there's a qualifier. So in this particular case, focal squamous differentiation, this is almost always a bad thing to see, oftentimes associated with a rare type of breast cancer called metaplastic, which takes on sarcoma-like features. Grade 3 gives you an idea of how aggressive this is. And then down below, you'll see the estrogen receptor, progesterone receptor, and proliferation rate, something we call Ki-67. Actually pay close attention to this. So to put things in perspective, for Burkitt's lymphoma, this Ki-67 sometimes is 99%. Triple negative breast cancer sometimes is 90 to 95%, which actually is quite fast growing. I've seen triple negative double in size within a course of 2 months. These are breast cancers that show up on interval breast mammograms. So someone may have normal breast mammogram 3 months prior coming in with a 2 centimeter breast mass. HER2 positive, we basically characterize this by IHC, which is just staining the cancer cells for that HER2 protein. If it's intermediate, then that gets reflexed either to what we call DISH or FISH, which is really just measuring how many extra copy numbers of that HER2 protein are present. And within this, the copy number ratio is here, and then HER2 signals per cell, but really you just look for this positive or not. A couple of caveats. Here at Providence, this gets run and resulted within just several days. At other institutions, they'll run FISH, which sometimes can take 2 weeks to come back. And so if you have a patient with newly diagnosed breast cancer, you're really just waiting on those results before you can formalize any kind of treatment plan. So breast surgery principles, you have several different options. One thing is becoming more popular is called the Goldilocks reconstruction, which is pretty neat. It's actually a mastectomy. And instead of patients undergoing an implant or something called a DIEP flap reconstruction, which is a rather major surgery, is the skin and subdermal tissue that's left over from a mastectomy gets folded into a breast mound. And it can be a pretty nice option for patients. A really important point here is if someone does not have a germline mutation, there's no difference in risk of local regional recurrence if you have a mastectomy versus a lumpectomy with radiation. So management of the axilla. In the past, everyone would have a sentinel they'd actually have an axillary lymph node dissection, removing multiple lymph node stations leading to lymphedema. Fortunately, we don't do this all that often. We've stepped back, and since they're doing sentinel lymph node biopsies, oftentimes 1 to 3 lymph nodes are removed, mainly to see if there's cancer cells in those lymph nodes to help with staging how aggressive I need to be in treatment. Or something called a targeted lymph node dissection, where if we know someone has lymph node positive disease, a Savvy Scout is placed in that lymph node so the surgeon can actually identify it during surgery. One thing that's really exciting was within the last year, 2 large studies have come out showing that for those patients that have low risk disease, whether it be hormone receptor positive, HER2 positive, or triple negative, we don't actually need to do a sentinel lymph node biopsy. And, for many people, and even I still struggle with this, I'm like, what do you mean you didn't do a sentinel lymph node biopsy? Like, I don't know if there's cancer in those lymph nodes until you remove them. But since I've understood this data, and it makes a lot more sense to me now. But really, with omitting a sentinel lymph node biopsy, lower risks of lymphedema, range of motion issues, frozen shoulder. And if you look at the risk of reoccurrence, there's absolutely no difference whether you remove those lymph nodes or not, which is fantastic. Part of this has to do with radiation includes whole breast, and part of that radiation also spills into the lower axilla. And so if there happens to be a couple of small breast cancer cells there, radiation should potentially take care of it. So is breast surgery needed? Now, I get this question actually a lot in clinic. And there's a study done out of MD Anderson called the Exceptional Responders Study Group, which actually was ongoing when I was there. And it's exciting to see the results of this. So this was a pretty interesting study in that they were able to pull this off, but it was for people that had a cancer less than 2 centimeters in size. They were allowed to have positive lymph nodes, triple negative and HER2 positive. They received neoadjuvant treatment, and really with modern treatment, roughly about 50 to 60% of patients will have no residual cancer at the time of surgery. So they underwent breast imaging biopsy, and if they found no residual cancer cells, these patients actually just went straight to radiation and never had surgery. If they found residual disease, then of course breast surgery, radiation, the standard pathway. For the 50 patients that enrolled, actually 8 patients had lymph node positive disease, and complete response was achieved in 62%, really kind of what we expect. For these patients that didn't have surgery, there was 0 rate of breast cancer recurrence and also no increased rate of distant metastatic disease either. And this was over 5 years. So there's plans to expand this study, but we're doing actually a pretty good job in medical oncology where hopefully one day we won't even need breast surgeons. I don't know. Maybe we'll all catch this before cancer even develops. But this came about for a patient of mine who's currently inpatient, and she had multiple comorbidities. We decided to go this route. She had extensive biopsy of her breast, and at the time she finished treatment, there was only the biopsy clip, so they biopsied around that biopsy clip. And she was admitted to the hospital, and CT scan was done, noting a 4-centimeter breast mass. And this was roughly about 5 weeks after this breast biopsy. So there was a concern, oh, she has recurrent breast cancer. This is related to her hospitalization. And, of course, we're going to get an ultrasound to confirm this, but breast cancer doesn't grow this fast to become a 4 centimeter mass. And looking at the exceptional responders study, I'd be very, very surprised if there's breast cancer here. But just kind of an interesting note when thinking about this. So what is really my role as a medical oncologist for early stage breast cancer? Receive the referral and really collaborate with our team, breast surgeons, imaging, pathologists to make sure we have all the workup that we need done, whether that be CT scans, MRI of the breast, additional biopsies. And really a big piece of this is chemotherapy needed or not? If yes, is this something that I want to give to a patient before surgery to either see how well it responds to treatment or make it easier to obtain negative margins, or if this is something that I give after surgery? What different targeted therapies do I want to combine with this? Largely dependent on the breast cancer subtype, comorbidities, and then when can I de-escalate treatment, which is really a huge focus of our world right now. So for many years, we kept giving more and more treatment to patients. But now we're starting to understand when we can really pull back, like for instance, not doing sentinel lymph node biopsies. And I think the most important thing is, what does the patient want? So there's several patients who have an international trip planned. The hard thing with breast cancer is it can affect very young women, older people, really at the prime of their life. For some reason, it's always after retirement, and I don't know what to make of that. But if they have a trip planned, there's really no rush for that patient to go to breast surgery if they have a slow-growing hormone receptor positive breast cancer. You can actually start these patients on endocrine therapy, and 3 months, 6 months, even a year later, you'll have downstaging of this tumor. And so if something is really important that's coming up, this is something that I often offer patients. Really, what is the expected response, treatment, prognosis, management of side effects, and of course, surveillance after surgery? What's the plan? So treatment of breast cancer has become incredibly complicated. Fortunately, there's a lot of research money, a lot of clinical trials, and also women who are willing to participate in those trials. So it's a very busy space. For metastatic disease, we have more and more targeted therapies that now we no longer know which one we should actually use because there haven't been head-to-head comparison due to these studies happening in parallel. So just basics. Hormone receptor positive, we always recommend anti-hormone therapy 5 to 10 years. Roughly 15% of these patients need chemotherapy now. So very few of these patients actually get chemo. Since we've started using oral targeted therapy, mainly these cell cycle inhibitors called abemaciclib or ribociclib for 2 to 3 years after surgery. And this can actually affect maybe 15 to 50% of patients may be eligible for this now. And there's a lot of advertisement going directly to patients on TV. For management of small triple negative and HER2 positive breast cancers, this is really controversial. We actually have an email thread called Breast Friends amongst all of us. And invariably, it's always these small tumors and what to do with them. There actually has not been a prospective randomized study for triple negative or HER2 positive breast cancers less than 1 centimeter in size, believe it or not. And a lot of us are still scared to de-escalate treatment. Triple negative, if it's larger than 2 centimeters in size, are lymph node positive. This includes multi-chemo drug regimen in combination with immunotherapy. Treatment for larger triple negatives and HER2 positives roughly span about a year. So imagine a patient's diagnosed with breast cancer. About maybe 3 to 4 weeks later, they're starting on chemo for maybe 4.5 to 6 months, surgery, radiation, and then in the adjuvant setting, things get a little bit easier with maintenance therapy. But this is actually a huge deal, right? Like we really need to step back on these treatments when we can. So for hormone receptor positive breast cancer, the reason patients don't automatically get chemo is that we've known for a long time these are hormone-driven cancers, particularly those that are more indolent. There's very little utility in giving these patients chemo. So different molecular risks tests were developed. First was actually MammaPrint and Blueprint, then Oncotype became more popular. But what these tests do is they tell you roughly what is the risk of breast cancer recurrence over a 10-year time period, and if there'd be any benefit of receiving chemotherapy or not. There's some differences between these two. In the last 5 years, we've kind of shifted away towards doing breast surgery up front, followed by molecular testing, and then giving chemotherapy after surgery or just hormone therapy. I will say that MammaPrint is more sensitive for African American females. So what's interesting about MammaPrint is it includes 150 genes. Oncotype only includes 16 genes, and both of these tests have been incredibly well validated in a prospective study with close to 10,000 women. So we have a lot of confidence in this. In terms of MammaPrint and Blueprint, though, it was able to identify women with higher molecular risk disease in about 50 to 60% of these patients, where Oncotype actually missed the majority of these diseases. So there's been a push within our community to make sure we're not ordering Oncotype on these patients. How I use this. So MammaPrint and Blueprint breaks it down into 4 different risk categories. High risk 2 is hormone positive breast cancer that behaves more like a triple negative breast cancer. So if you give these patients chemotherapy, anywhere between 30 to 60% will have no residual cancer at the time of surgery, and that they're actually potentially sensitive to immunotherapy. So we have a clinical trial that's ongoing right now, put several patients on, looking at incorporating immunotherapy for this. High risk 1, these patients actually receive less chemo than high risk 2. Low risk and ultra low risk. Now, these are what we call more luminal breast cancers. For ultra low risk, there's 2 different studies done. And even for patients who had lymph node positive disease, risk of breast cancer recurrence over a 5-year time period was only 3%, whether or not they received endocrine therapy. And so I'm starting to de-escalate duration of endocrine therapy for these ultra low risk patients, just because we have that data to support it, particularly if someone's not tolerating it well or is older. Some of the basics about hormone replace or not hormone replacement therapy, endocrine therapy options. Tamoxifen really being the first in development. Aromatase inhibitors, the way that these work is after menopause, your body is still producing estrogen from other sources, mainly adipose tissue. And these will inhibit aromatase and actually take the level of estradiol and lower it even further. There's a correlation with BMI and actually aromatase activity that in part might be due kind of relate with how obesity correlates with breast cancer. So in terms of effectiveness, tamoxifen is slightly less effective than aromatase inhibitors. So if someone has very high risk disease or molecular risk disease, I tend to try to get them on an aromatase inhibitor. But of course, much of this depends on tolerance. Tamoxifen is generally better tolerated than aromatase inhibitors. There's some nuances in terms of side effects between the two. Slightly higher risk of hot flashes with tamoxifen. Aromatase inhibitors can cause a lot of arthralgias, and in a lot of ways, this mimics an inflammatory arthritis. So these are patients that wake up, complain about being stiff, and as they get moving about, things start to loosen up. And sometimes it can be quite severe, where they can develop trigger finger, carpal tunnel, tendinitis. It tends to affect the smaller joints rather than the larger joints. But unfortunately, there aren't too many treatments that we can do to help with this. And part of it is estrogen is important in low estrogen states will actually cause inflammation in the synovial fluid, which is some of the work that they've done in mice. Aromatase inhibitors have much higher rate of vaginal dryness. Tamoxifen has a very slight increased risk of endometrial hyperplasia, ultimately endometrial cancer, particularly for those that are on tamoxifen for over 5 years, like closer to the 10-year mark. Fracture and osteoporosis is definitely something we see with aromatase inhibitors, but typically if someone starts out with a normal bone density, after 5 years of an AI, their bone density will still be within normal range. So as I was mentioning, we're starting to step back from our treatments. So when tamoxifen was first developed, they gave higher and higher doses of tamoxifen to patients because it's really one of the first targeted therapies for cancer, all cancers. And they landed on 40 milligrams. And then patients said, well, this is way too much. And they bumped it down to 20 milligrams. And that's where it's stayed for decades. What's really interesting is if you give as low as 1 milligram of tamoxifen to luminal breast cancer before surgery, you can actually see apoptosis and cell death. You can see a suppression in the Ki67. And stemming from this, the Italians did a study looking at 5 milligrams of tamoxifen compared to 20 milligrams for patients with DCIS when used as prevention. And they found no difference in increased risk of breast cancer with that ultra low dose. So LOTAM is a clinical trial that was started, cooperative group for patients with low molecular risk invasive disease. And you're randomized either to LOTAM or treatment of physician's choice, which some patients struggle with. But I'd like to highlight that across all 270 sites where this trial is open, if you look here, us at St. V's were one of the top enrolling sites for this trial, which is wonderful, right? But it's an exciting trial, and I think, truthfully, will come with a lot fewer side effects and will become standard of care once we have more follow-up with this. Estradiol PET scan is really pretty exciting. What this is it uses estradiol instead of your standard FDG PET to try to identify, are there areas of breast cancer metastases? It has a little bit of a kind of limited utility. It's FDA approved. We're still trying to figure it out. The tracer has to come from far away and get shipped here. It's expensive. Where it's sometimes helpful is in patients with lobular breast cancer. Again, these are ones that are hard to image, or those that are slow growing, low proliferative rate, are not using up a lot of sugar. Those tend to not be very avid on PET scan. So, Namari, this is a patient of mine who had been diagnosed with CLL and SLL for about a decade, and she developed a new breast mass. Her FDG PET scan showed multiple lymph nodes involved, including both axillas, thoracic lymph nodes, and it was really challenging. You know, these kind of bone lesions down here didn't light up on the bone scan, maybe degenerative changes. And so I said, you know, I'm not quite sure if this is metastatic disease or what, but in this particular case, I got an estradiol PET scan, and you can clearly see that every single one of these lesions is actually hormone receptor positive breast cancer, not CLL. Some of the caveats is that the liver actually has estrogen receptors on it, and meningiomas also will, so you can't really use this in terms of determining where disease is. It's not like a PET scan that tells you how active the cancer is, but mainly just used as, where is this cancer? Sometimes it's helpful if breast cancer will lose the estrogen receptor, and then you can use this to guide where you might want to biopsy it. So, role of tumor-infiltrating lymphocytes, mainly in triple-negative breast cancer. So as I was saying, for those with very small tumors, we really don't quite know if they need chemotherapy or not. Generally, if something's about a centimeter in size, we'll give 6 months of chemotherapy, including an anthracycline that has kind of obvious impacts in terms of cardiomyopathy at later ages, increased risk of MDS and leukemia. While that's less than 1%, I've known of 2 patients who have developed anthracycline-induced MDS. So one thing that's interesting is that what they've noticed is that within triple negative and also other breast cancers is tumor-infiltrating lymphocytes. So this is all done on an H&E, just routine biopsy. The pathologist can characterize, okay, where are the breast cancer cells, and are there any lymphocytes near that breast cancer? Meaning, is there some immune cell recognition of that cancer? Are these cells primed to control the cancer? And they've characterized it in different cutoffs. For those that have low tumor-infiltrating lymphocytes, less than 30%, if they have a stage 1 triple negative, risk of breast cancer recurrence or disease-free survival is 78% if they do not get chemo. Now, if they do get chemo within this group, typically risk of recurrence is less than 5%. So this is clearly a patient that you want to give chemotherapy to. For those that have high TILs, now what's interesting is if they don't get any chemo, risk of recurrence is less than 5%. So while this is not currently in our guidelines, if I have an old patient who has a 1 centimeter triple negative breast cancer, I am using this because first off, we don't have data. Our guidelines are very vague, and we need something to go off of in terms of actually making a decision for the patient. So more to come with this. For triple negative, for larger tumors, standard of care is a 4 different chemotherapy regimen combined with immunotherapy, followed by surgery. And the most important thing is there residual breast cancer or not at surgery? And that's something that we call pathologic complete response or residual cancer burden. So when I first see a patient, even with stage 2 or stage 3 breast cancer, they ask what my prognosis is. And I say, it's really hard for me to tell right now. We need to see how this responds. For patients that have no residual cancer, their risk of recurrence is less than 5%, even for lymph node positive disease. So you often hear patients say, I have triple negative. This is the absolute worst. I'm going to die. Yet, if we can get to that pathologic complete response, which now happens in approximately 65% of patients, I can say, hey, your risk of recurrence is less than 5%. Now, the same is not true for someone who has a lymph node positive, hormone receptor positive breast cancer. The lowest that we can currently bring that risk down to for lymph node positive disease is less than 15%. So in some ways, triple negative includes a lot of chemo, but there's different things that we're doing to de-escalate. If there's a lot of residual breast cancer, meaning chemotherapy didn't really touch this, these patients are in a lot of trouble. So risk of recurrence, even within 12 months, is roughly 50%. With recurrence, these patients most often don't make it past a couple of years. And so I really worry about these patients that don't quite get there. Moving on to early stage HER2 positive breast cancer. This can actually be quite an aggressive disease. So without any treatment, even for these very small tumors, less than 5 millimeters in size, risk of recurrence can sometimes be 20%. This was seen in these 2 older studies. Now, there's been some SEER database showing that it may not be quite that high, but it's difficult to know. So management includes, for small tumors, we do surgery first, and then we actually recommend chemotherapy for 3 months, combined with anti-HER2 therapy, which are 2 different antibodies that target that HER2 protein. What's interesting in mice is for these antibodies, if you actually deplete their T cells, Herceptin has no effect on breast cancer. So this really occurs through kind of immune-mediated ADCC, which is pretty interesting. Larger tumors, we give chemo followed by surgery, determine if there's residual disease, kind of seeing a trend here, escalating adjuvant treatment if we need to, or stepping back and doing more of a maintenance treatment. For prognosis, small tumors, risk of recurrence is less than 5% if adequately treated with chemo combined with anti-HER2 therapy. Larger cancers, again, it kind of depends on whether they have a pathologic complete response. So a lot of work is being done in terms of de-escalating treatment. And this is a clinical trial that actually David Page, who's over at Providence, Portland, in collaboration with Heather MacArthur's at UT Southwestern, developed. Instead of using two different chemos, what they did was they gave just one chemo, taxane, combined with Herceptin and Perjeta. And this was the control arm. And then they also included immunotherapy, which currently is only FDA approved for triple negative breast cancer. And then they had another arm here, arm C. What was really exciting about this study, this was presented at San Antonio just recently, is that difference in pathologic complete response rate was roughly about 15%. And so this is in the process of moving forward, and hopefully additional studies are going to actually establish immunotherapy as standard of care for this to allow for us to de-escalate chemo. A lot of work is being done in terms of spatial analysis, understanding what are these immune cells that are near the cancer, are they activated by immunotherapy or not? And then one thing that's really exciting yet incredibly controversial is use of circulating tumor DNA for breast cancer. And this is really pretty exciting technology. What's done is a company does deep sequencing of breast cancer. They identify a panel of mutations, and then they look for these mutations in the blood. So all breast cancer will shed some DNA into the blood, and then that can be detected by really ultra-sensitive methods. If someone has circulating tumor DNA that's positive before surgery, they have a higher risk of reoccurrence. But if you give them treatment prior to surgery and they actually clear that circulating tumor DNA, risk of reoccurrence is really less than 5%. And with newer generation of these tests coming out, it's actually predicting risk of recurrence even more so than pathologic complete response. And you can actually monitor this every 3 months or every 6 months. Again, still controversial, trying to figure out what to do with this information. If it's detected, oftentimes it leads to a lead time biopsy of diagnosis about 3 to 6 months prior to there being radiographic recurrence. And so in starting treatment like earlier, are we actually kind of stimulating resistance later on? So we have a lot of different clinical trials that are open, really, really exciting things. And then I'll just kind of briefly go through survivorship. So timing of recurrence is pretty critical. So for luminal, slow-growing hormone receptor positive breast cancers, these are breast cancers that can occur 5 years later, 10 years later. The longest time I've seen was 27 years after diagnosis. For those that are HER2 positive, triple negative, most often within the first 2 to 3 years. And even for small hormone receptor positive breast cancers, after these women complete 5 years of endocrine therapy, risk of recurrence over 20 years can sometimes be as high as 20%. And this is really for a cancer that's less than a centimeter in size, which is quite shocking if you think about it, right? So this is why we'll oftentimes recommend endocrine therapy for as long as 10 years. Publication came out over the summer that was really interesting. And what this was looking at was this idea of breast cancer dormancy. How is it possible breast cancer can stay dormant for 20 years and then come back? And within this, they identified that possibly flu and COVID can stimulate the growth of any dormant cancer cells within the lung. They initially looked at a breast cancer model in mice that developed spontaneous lung metastases. And they found that this is largely due to a particular inflammatory cytokine called IL-6. So if you actually have wild type, these cancer cells will reactivate, particularly when stimulated with the flu. If you knock out IL-6, you see a dramatic reduction in the number of breast cancer cells within the lung. So on a population level, I actually have printed this study out and given it to patients so they can get their flu vaccine, and it's made a difference. Along with this study, they also looked at COVID-19, and within the Flatiron database, this was during the first 2 years of COVID, and so it's a little bit hard for me to know what to make of this. But generally, what they found was that for those people that had PCR positive COVID-19 tests, those patients had a higher hazard ratio of risk of breast cancer recurrence in the lung. But again, this data, even though it's very large, it's a little bit shaky just knowing what was going on at the time. So I have 5 minutes remaining. We'll flip through this really quickly. Topical vaginal estrogen. This is very, very controversial. And at San Antonio this year, there is actually a lot of dialogue surrounding this. People are very, very vocal about this, and I get why. I see these patients every day, and we have this conversation frequently. So who's really the ideal candidate for vaginal estrogen? So vaginal dryness can happen in patients who are young, getting chemo, early induced menopause, those who are on aromatase inhibitors. And discontinuation rates of endocrine therapy can sometimes be as high as 30% for vaginal symptoms alone. So there's been several meta-analysis. In the past, we thought, why would you ever use topical vaginal estrogen? This is completely indicative of what we're trying to do here. Several large meta-analysis was done. They actually showed no increased rate of breast cancer recurrence, mortality, or even overall mortality. But with all of these studies, they're very difficult to interpret. Majority of these women were lower clinical risk and actually received tamoxifen, and tamoxifen basically blocks any estradiol from attaching to the estrogen receptor. So if someone's having some systemic absorption, it's not as much of a concern. Aromatase inhibitors, it is a little bit more of a concern. But within this meta-analysis, one study, Danish study it was called the Cold Danish study, but approximately only about 12% had stage 3, about 50% used an aromatase inhibitor. They used higher doses of vaginal estrogen than what we typically do, and they identified a risk of recurrence in those that were using an AI. There's another meta-analysis that came out recently, also kind of supporting what that particular retrospective study showed, with an increased risk of breast cancer recurrence in those that use aromatase inhibitors, but no increased risk of mortality. Systemic absorption has been looked at, but a lot of this PK data is a little bit shaky. So even with 10 micrograms, which is roughly Vagifem, there is an increased dose and level of estradiol, but then it kind of goes to normal out to day 14. But typically for breast cancer, if someone's on an aromatase inhibitor, our goal is actually an estradiol less than 2.7. And at these ultra low ranges, you actually need LC-MS/MS to detect this, which is not routinely done within LabCorp. But we still are trying to understand really how low do we need to bring someone's estrogen to protect them. Maybe circulating tumor DNA can kind of give us some reassurance. And how I approach this is honestly, it's a risk-benefit conversation with patients. How symptomatic are they? I have no problem in prescribing these, particularly if they're helpful, but really trying to use the lowest dose as possible. So now there's as low as 4 microgram tablets that are available. Of course, I do worry if someone has a large breast cancer, multiple lymph nodes, is on aromatase inhibitors, premenopausal, and say, okay, well, maybe let's try to do this for a year, then introduce some topical vaginal estrogen to help you out. And with that, just like to say thank you. This is my colleague, Dr. Top. Her office is right next to me. We have a lot of fun in clinic. I call it Breast Side, West Side. Prov Portland, Sasha Stanton, David Page, Ali Conlon. You all probably know them. And Kelly Perlitz down Newburgh. And really thank you to the whole breast team, pathology, or clinic nurses and MAs. One thing is please reach out if you have any questions. And with that, I'll leave it. Thank you.
Well, thank you so much, Dr. Hobbs. I will acknowledge we're at 8:59, so people who need to move on, feel free. If there's one burning question, we can perhaps take it.
What is your thought about tamoxifen for primary prevention as a QI project in our resident clinic? I've felt guilty for years that we haven't done it. And now that you showed we don't have to give 20 necessarily,
Yeah.
we could give 5. I'm like raising it again.
You should.
We rarely do it.
Yeah,
Yeah.
I mean, even in uptake is roughly about 5%. And so much of it comes down to counseling. So if patients truly understand what their risk is, they're more likely to take tamoxifen for prevention. 5 milligram dose is very, very well tolerated. Certainly some people will have a lot of symptoms even from that. And I'll have them take 5 milligrams every other day. Some tamoxifen's likely better than none. And there are some differences in terms of metabolism. So I would recommend 3 years for what we call the baby TAM study out of Italy. We now have 10-year follow-up with that. But I think there's a lot of work that can be done. We see a lot of patients here, and it really offers a lot of kind of opportunity to do these kind of studies. So yeah, thank you.
Great. Thank you so much, Dr. Hobbs.